Oh, hey nurses. Advocate Maggie, been a nurse for 24 years, and have you seen that what they're saying, they're going to cap anesthesia coverage at certain time for Connecticut, New York, and Missouri? So what one of my spidey senses tell me immediately that they'll be abusing RNs in these situations. Why do I know that? Because I've been a procedural nurse. In my master's degree, I created a tool for some of this very reason. I was working primarily interventional radiology, one of the scariest spots in the hospital for a nurse to date. It's outright scary if they don't use anesthesia. Let me tell you, it's why I created that tool. Cath lab, endo. Endo's another scary spot for nurses that are given sedation as well. They have been using anesthesia way more in that area, but it was traditionally a lot of RN sedate, and I don't feel like it's safe, and that's why I created that tool. When they're asking me to push the GI doctor, let me be real clear. You're not standing there with the critical care doctor. The GI doctor is telling you to push Phenergan or Benadryl as an adjunct to fentanyl Versed. Oh, it can be very scary, and why I created that tool. And you have to be real comfortable with your skills, and no, you have to say no. So one of the criteria for an RN not to sedate is time. No, if the procedure is going to go on for hours, that actually discriminates us from sedating that patient. And who sets that criteria? The American Association of Anesthesia, right? So if you're sedating patients as an RN, you need to go to your board of nursing and you need to read what the criteria says for conscious sedation for an RN, because that's what you fall under. You hold an independent license. You don't work under that doctor. I don't care if it's the interventional cardiologist, the interventional radiologist, endo, pain, whomever standing there. I've stood there doing pain procedures. The anesthesiologist was giving me, because the anesthesia provider was doing the procedure to give the sedation, right? But if it's not safe, I still have a duty to say no. So this just makes me really worried about, of course, the patients and then not getting the care that they need, but pushing nurses into positions where they're going to be placed to sedate. And again, why I created that tool, 7 questions. The scheduler could use it. It is not, if any of them say yes, they have to be bumped over for anesthesia to evaluate to make sure that they are safe to sedate. Because RNs, if they have an ASA 3, stop it. Unless they're STEMI, you're not sedating them. You better be real comfortable with what Mallampatties are, with what ASA screenings are, with Part B when it comes to, we don't fill that out, but the doctor does when we're sedating the patient. You need to understand what that says and what that means. Yes, it's tied to billing, but there's specific criteria there as well. And if you're taking on the role as an RN sedator, please, especially in these states, right, where Connecticut, New York, and Missouri, where we could see some practices. And do I know? No, I don't. But I've been in this world for 24 years. So please be careful. Don't get roped into this. You have to say no. You have to set your boundaries. Do not place yourself as an RN into situations because they're not going to be able to get anesthesia or pay for it, whatever it is. But no. And I don't know how this is happening. This is whoever the doctors are for these insurance companies. I hope they're being investigated because that's criminal.